Good afternoon, and welcome to the Johns Hopkins 30-minute COVID-19 briefing, where we provide live insights from the experts who lead our work at the Johns Hopkins Coronavirus Resource Center. For the next half hour, we'll focus on what you need to know right now about the COVID-19 pandemic and public health responses. As part of this briefing, we'll have an opportunity for live Q&A with our experts, and we'll be offering these 30-minute briefings regularly on Fridays at 12 p.m. I'm Dr. Lainie Rutkow, a professor in the Johns Hopkins Bloomberg School of Public Health, and I'm part of the leadership team for the Johns Hopkins Coronavirus Resource Center. We'll be providing answers in real time today, so please submit your questions in the box at the bottom of your screen. Before I turn to our experts, I wanted to let you know that the Coronavirus Resource Center recently launched a newsletter called The Week in COVID-19. It's a great way to receive the latest analysis from our experts every Monday on vaccines, variants, and other vital COVID-19 trends. You'll see sign-up information in the banner during your screen while we're in this briefing. Today, I'm joined by two guests. Dr. Jennifer Nuzzo is a senior scholar at the Johns Hopkins Center for Health Security and an associate professor at the Johns Hopkins Bloomberg School of Public Health. Jennifer will give us an update on the public health implications of the COVID-19 data. We're also joined by Dr. Brian Garibaldi. He's the medical director of the Johns Hopkins Biocontainment Unit and an associate professor at the Johns Hopkins School of Medicine. Brian will give an update about the treatment of COVID-19 patients. I'll now turn to each of our speakers for a brief overview. Jennifer, it's been exciting to see states expanding eligibility for vaccines over the last few weeks, but unfortunately, we're also continuing to see some troubling trends, especially with daily new cases on the rise. So my question is, are you feeling optimistic, concerned, or a mix of both?
Yeah, I'm feeling a mix of both. I mean, where we are today in terms of spread of COVID in the US, we've basically plateaued. That means that the weekly case numbers that we saw this week is essentially unchanged from the previous week. That is somewhat to be expected in the rollout of the vaccines, and as we continue to expand who is eligible to get vaccinated, I expect that we will see further drops in cases, which is really important. So that's why I'm happy to see that eligibility will be expanding, and hopefully access will also be expanding with additional supplies of vaccines. That's going to be absolutely critical. So it's a mixed case that we are seeing a plateau right now. It's good that we are no longer seeing those surging increases across the country that we saw around the holiday period. But this plateau, while possibly expected and for the time being until we further expand eligibility, is happening at very high levels. So I think we have to take a reminder that the number of cases that we are seeing each day is still dangerously high, and there still is potential for the spread of this virus to outpace our efforts to vaccinate people. In particular, we're worried about a few parts of the country where we're seeing rising cases. 19 states in the last week saw their second week of case increases. So that suggests that the trends are obviously headed in the wrong direction in now a number of states. Still, all eyes continue to be on Michigan with the spread of COVID there. We're also seeing an increase in hospitalizations in Michigan, which is concerning. Across the country, deaths continue to decline. It was 16% lower in this last week than the prior week. So that is, of course, good news. And it's what we like to see with the rollout of the vaccines, further reduction in deaths. That is good news. That said, there are 3 states for which death numbers have been increasing for more than 2 weeks: Virginia, Michigan, and Washington. One of the concerns that I have is that as we see an increase in cases, it takes a while for that to translate into potentially hospitalizations, and then even longer to translate in deaths. So we have to be mindful of the data looking forward, and I don't want to see increases in hospitalizations and deaths in other states. That would be a worrisome trend, particularly since we have vaccines that will prevent both of those things. So again, adds urgency to the need to roll out vaccines. The other area where I have some concerns is on testing. pretty much since the beginning of January, we've now seen more than 27% drop in the number of tests being performed each day. We've talked about this before in other briefings like this. Some decline in testing may be expected with case numbers having fallen since our holiday surge, but when we have been looking at testing, we have seen this downturn happen prior to the decrease in cases. So it really seems like there is something else going on. We've heard about states basically shifting their focus almost entirely from testing to vaccinations. Understandable given resources and given the priority on vaccines, but testing remains essential. With dangerously high case levels, we still have to do our part to identify infections and make sure we isolate them so that they don't spread to other people. We also need testing because it is the foundation of our surveillance for this virus. And I am deeply worried that as states have scaled back testing, they are starting to develop blind spots in their surveillance for this virus. So we need to be very mindful of that. And one area of concern is that testing and identifying infections is the first start to conducting surveillance for the variants. So if we erode our surveillance capacities, if we continue to see these declines in testings that aren't fully just a result of declining infections, it is possible that we could be quite surprised to suddenly find a rise in cases that had been resulting from infections that were spreading silently for quite some time. So that's what I'm concerned about this week. And I really hope that with additional resources from the stimulus that states will be able to expand testing and restore to the pre-January or greater levels of testing.
Thanks so much, Jennifer. Before I turn to Brian, I want to remind our audience, please do submit questions for our experts in the box at the bottom of your screen. Brian, last month's decrease in hospitalizations unfortunately seems to have plateaued. My question is, as a clinician, what are you seeing now in the ICU and more generally in the hospital?
Thanks, Lainie. Well, we have seen, unfortunately, here in Maryland, a steady rise in the number of patients who are hospitalized with COVID, and we have started to see that sort of slightly delayed rise in ICU admissions. So here in our health system, we've had to open new units again to expand our capability for taking care of hospitalized patients. As Jennifer mentioned, we have not seen we've seen declining death rates across the country, but that's a lagging indicator. So I'm worried that we might start to see the death rate creep back up because we are seeing some rises in hospitalizations. I think one change that seems to be true across much of the country is that the age of people who are being hospitalized is a little bit lower. And that probably reflects a combination of different factors. One is that we've done a very good job, I think, of vaccinating older individuals. We know that age is an important risk factor for bad outcomes from COVID. And I think we've done a pretty good job getting people vaccinated who are older. And I also think that it reflects behavior change amongst younger people who there's obviously a lot of pandemic fatigue out there. People are, spring is here. People want to go enjoy outdoor activities. They want to go back to the things that they like to do in the spring. And I think we're seeing a rise in cases in younger demographics, the 20 to 39-year-old group and the 50 to 59 has been driving some of the rise in hospitalizations. And so that's something that I think we need to keep an eye on is, there is good news. Last weekend we had a 24-hour period where more than 4 million people were vaccinated in over the holiday weekend, which is amazing. We've had over 30% of the U.S. population that's gotten at least one shot. So, I think we're getting closer to the point where we're going to really see the impact of those vaccines on decreasing in the number of cases and decreased hospitalizations, but we're not there yet. And so I think people who are not yet vaccinated need to remember that we do have high levels of circulating virus in the community. And the other factor that could be at play here for the younger people being hospitalized is that we know that some of these variants have the potential to be more transmissible, but also have the potential to cause more serious illness. And so that's something that we're looking out for. And thankfully, we've had an increase in the number of cases that we're able to genotype. So we're starting to get a better sense of what variants are circulating in different communities. But I think that's something we need to be mindful of. I did mention there is some good news. Obviously, the vaccinations have continued to increase, which is wonderful. Last week, Pfizer released some results from its adolescent trial. They had about 2,200 individuals between 12 and 15 who received both doses of the Pfizer vaccine, and the immune responses were quite robust and were as good, if not better, than what was seen in the older age groups. and there were no reported symptomatic cases in those who were vaccinated. So that's a hopeful sign that vaccines, at least for adolescents, are on the way, and that would do a lot to help us continue to expand our ability to get people back to school, to get back to sporting activities, and to keep children safe. And there obviously are other studies ongoing for younger kids, so we're still hopeful that we'll continue to move towards having vaccinations for children as well. There's been some promising reports from the CDC about what fully vaccinated people can do. The ability to travel and the ability to spend time with other vaccinated people, I think will continue to expand, and hopefully will be an incentive for people who are still on the fence about whether or not they want to get vaccinated to recognize that there are benefits to you personally in terms of what you can do with your activities safely, but there's also obviously the benefit to those around you, your loved ones, your family, your community. And then I also think it's important to remember, the social distancing methods that we have in place right now are impacting other diseases. We are still at very, very low levels of seasonal flu and other viruses that, like respiratory syncytial virus or RSV, that every year cause hundreds of hospitalizations and death in kids, and thousands of hospitalizations and deaths in adults when we're talking about influenza. And we are really at very low levels of that. So there have been some benefits of us continuing that vigilance that's hopefully going to help us beat back COVID, but is also having an impact on other respiratory illnesses as well.
Thanks, Brian. I'm now going to turn to the questions that are coming in from our audience. And Brian, first question is for you. What do we know about those who have so-called long haul COVID and getting immunized? So if you're fully immunized, does that seem to offer any protection from developing long haul COVID?
Well, I think that there's two parts to that question. The first is that, if you're fully immunized, you're very highly protected against getting COVID in the first place. So the best way to prevent PASC is to not get COVID. And so I think the vaccines are going to do a lot to prevent additional people from developing this long hauler syndrome, or what some people call it the post-acute sequelae of COVID, or PASC. There are reports that are emerging that some people who have had months of persistent symptoms after their initial COVID infection have felt better after they've gotten the vaccine. And depending on where you're looking, some cohorts have said up to maybe 30 or 40% of people have noticed improvements in their symptoms almost back to baseline after they've gotten vaccinated. We're not sure what to make of that yet. These are still at the level of sort of anecdotal reports. We need to get more information, particularly about what's happening to these people's immune systems. But there's some thought that perhaps in a subset of people who have these persistent symptoms, maybe they actually have low levels of viral replication in immune privileged sites, sites where the immune system hasn't been able to get rid of the virus, and it's not at a level where we're able to easily detect it. And so there could be something that's happening where they get vaccinated, their immune system all of a sudden has a much more robust response against the virus, and they clear the virus. So that would be wonderful if that's happening. We need more data on it, but it is also clear that it's not happening in everybody. And I think what that probably means is that long COVID, or these long hauler symptoms, are probably heterogeneous, right? They're probably caused by a number of different factors, and there are different phenotypes. Some people might have neurologic symptoms, some people might have symptoms of palpitations, some people might have lung symptoms, and I think the causes may actually be different in each one of those cases. So there may not be a one size fits all treatment or way to prevent it.
Got it. Thank you. And Brian, another question for you. For those who have gotten the COVID vaccine but have experienced no effects afterwards, so they don't have a sore arm, they just feel fine. What, as a clinician, would you tell them about their concerns that maybe it's not working?
So, everyone is different in terms of their response to the vaccine. We do know that these are immunogenic vaccines. They cause an inflammatory response in many people, but there's no clear association with, you had worse symptoms after your second shot, and therefore you're more protected against COVID. We still don't know what COVID antibodies mean. If you actually test people's antibodies after a vaccine, I was part of a trial where I know what my IgG against the spike protein is, but I have no idea what that means in terms of its ability to protect me from getting the virus. What we do know is that if you look at the large number of people who've been vaccinated, both in the trial data, but also in the real world data, these vaccines are highly effective at preventing symptomatic disease. They're probably very effective against preventing asymptomatic disease, and they're incredibly effective against preventing hospitalization and death. So if you've been vaccinated and you're 2 weeks from your second Pfizer or Moderna shot or your first Johnson & Johnson shot, then you should be very confident that you have protection. But also remember that it's not 100% protection, right? You still need to be mindful of the high levels of circulating virus in the community, and you need to be, I think, aware of your surroundings, aware of your activities. And also remember that just because you're vaccinated doesn't mean that the person next to you is. And I still think we have a responsibility to do our part to prevent the spread of this virus, even if we're vaccinated.
Thanks, Brian. Jennifer, a question about rate of vaccination versus daily new cases. So how do you look at those different trends? And then how does it make you feel about this question of are we outpacing the spread of disease with the vaccine rollout?
So I continue to be optimistic because of that. I mean, right now the vaccinations are occurring at a clip and happening quickly in a way that is greater than the increase in cases that we're seeing. But of course, the possibility remains that that could change. And so I am, cautiously optimistic that we will be in a better place in the coming months. But we're just so close to the end. It almost feels like we've been running a marathon and we're finally seeing our family and friends near the finish line. We can't stop now. We are very close. So I think there's reason to be hopeful, but also reason to be concerned that we could, have some setbacks.
Thanks, Jennifer. And another question for you. When you spoke about testing before, you alluded to sequencing to better understand variants. Can you speak a bit more about that? Do we actually have statistics about, the percentage of positive tests that are analyzed for variants? How does that work?
Yeah, so I think it's a bit of a misnomer or misunderstanding about how we look for variants, because I see a lot of stories talking about the increasing. The best way to tell if the variants are increasing is to look at the percentages of sequences that are done, and how many of what percentage are coming back as being variant cases. That's different than just looking at the number of cases of variants reported, because again, we have to root it in the denominator, which is that how many of our cases are we looking at to see if they are in fact caused by the variants. Even that is still not a great way to tell us what the prevalence or incidence of variant infections are, because we may not sequence, the way that we pick cases in order to send them to sequence may be a bit biased. And so there are some locations that are actually taking a much more kind of thoughtful approach where they are trying to sequence cases with respect to the underlying population to make sure that it's representative of the cases that they're having, to try to better eliminate biases in terms of which sequences they look at. But I think the overarching finding from this week is that B117, the variant that was originally detected in the United Kingdom, is becoming dominant, which is expected given the increased transmissibility associated with that. But what we still don't have a great sense from is just how truly representative it is of all of our cases. So I think we have more work to do on the surveillance to understand how widespread it is and in all age groups. But I think we should expect to see more of these cases, and that is possibly why we are seeing an increase in cases in places like Michigan.
Thanks, Jennifer. Brian, question for you about discharge protocols. So for those who have been hospitalized with COVID, how does it work when they're discharged? Is there some kind of exit testing regimen for them? What's the process?
Yeah, so a lot of that depends on how sick they were and what their unique context might be. But in general, for people who have been in the ICU, we think it probably, many of them are going to be in the hospital for many weeks. And by the time they're discharged from the hospital, they're probably outside of the window where they would be infectious. So in our hospital, we've used 20 days from the the start of your illness. If you're still in the hospital, we actually are able to take people off COVID precautions and move them out of a COVID isolation unit to a regular floor. For people who have not required ICU level care, it's probably around 10 days. There's no requirement to get tested again. if you're 10 days out from your initial infection, you weren't in the ICU, you're feeling better, you're not having a fever, it is very unlikely that you would still be infectious to someone else. So we're not doing, by and large, we're not doing testing out, procedures where someone has to test negative before they can return to their home. That's probably a facility by facility decision. There are some areas where they're being maybe a little bit more cautious and requiring people to test negative before they go back to their assisted living facility, for example. That's a policy in several states. So I think it's probably a regional specific thing, but in general, about 10 days, if you haven't been in the ICU, you're feeling better, you're probably no longer infectious. And I think 20 days is very conservative. That's what we've been using in our ICU population to say, all right, you're probably no longer infectious.
Thanks, Brian. Jennifer, question for you. Given what we're seeing in Michigan, what you spoke about earlier, do you think that the federal government should be prioritizing vaccine for that state? Or do you think, just given where we are in the pandemic, it makes sense to stick with the population-based formula that's being used?
I do think we should prioritize places that are experiencing acute rise in infections. I mean, the biggest tragedy right now is that we have vaccines on hands that can prevent hospitalizations and deaths. And when we see a rise in that, I mean, I think it makes sense that we should act swiftly to try to prevent that from happening. And so if there are states that are struggling more than others, I think it makes sense for them to get additional vaccines. I think that we will see an effort to do that. I saw some news today suggesting that the administration may be considering doing that, or perhaps already underway. But this has been something that a number of people have called for now for several weeks.
Thanks, Jennifer. Brian, question for you. In the hospital, have you seen instances of those who are fully immunized needing hospitalization?
So I personally have not. We do track the number of people who have been vaccinated who get sick, and it's a very, very low percentage of people who develop symptomatic disease. There may be a handful of people who've been hospitalized after their second dose. We have unfortunately seen people who get sick, between their first and second dose when they don't have full protection. Maybe they were even exposed before they got vaccinated. But we are not seeing a large number of people getting hospitalized after they've been fully vaccinated. Again, that means 2 weeks after your 2-shot series, if it was Pfizer or Moderna, or 2 weeks after your single shot Johnson & Johnson vaccine. But I think it's really important that people remember, just because you got the vaccine does not mean you've developed that immune response yet. So if you really want to be maximally protected, you want to wait at least 2 weeks after that second shot, or the completion of your series. And there actually is pretty good data from the Johnson & Johnson vaccine that the immune response continues to get even better after that 2-week period. So the longer out you are from your J&J vaccine, there may be actually more protection. So again, I think people just need to be mindful. Just because you got the vaccine, you need to wait until your immune system has responded before you really will have that maximum protection.
Thanks, Brian. Another question for you about PASC, or long haul COVID. For folks that are experiencing it, how long do we think they can continue to shed virus?
Well, for most, we don't think PASC, by and large, we don't know what the etiology of it is, and there's lots of energy being directed towards understanding this. We don't believe that people with PASC or long COVID are infectious. If there is some level of underlying, viral replication in their body, it's not at the level that we can, by and large, detect it, and would be very unlikely that they would be able to spread the virus. And again, I think, this long COVID syndrome, it's going to take us a while to unpack what really causes it, how much of it is related to the specifics of being infected with SARS-CoV-2, the virus that causes COVID, how much of it is being sick with a virus in general. We know that other viruses can have post-viral syndromes. We've seen this after the H1N1 pandemic in 2008, 2009. We definitely saw it after the pandemic influenza in 1918. We've seen it after SARS and MERS. So how much of it is specific to COVID, we really don't know yet. And then how much of it could be other things? There's so many other factors that are changing in our lives, and so many other stressors, that I think it could be a combination of having been infected with the virus, and also how everything else is happening in your life, manifests in symptoms. We know this happens with other diseases as well, that your symptoms are multifactorial. Part of it is the virus itself or the infection. Part of it's your genetic makeup, part of it's your environment. And I think this is a critical question because we have millions of people who have been infected with COVID and lots of people at risk for these long-term symptoms. And I think this is a priority both here at our institution, but nationally. The NIH has put billions of dollars towards this over the next 5 years to try to understand what causes this, how do we treat it, how do we prevent it, and that's happening all across the world. So I think we're going to be learning about this for many years to come.
Thanks, Brian. Jennifer, question for you about disparities and the pandemic. What do we know, especially in terms of deaths, about disparities, and also where do you see gaps, especially in data and reporting, that need to be fixed?
I think if there's one lesson that we could take from this pandemic is that we have not all suffered equally. And there have been clear disparities since the beginning in who gets COVID, who's hospitalized from COVID, and who dies from COVID. And now, unfortunately, we are also seeing disparities in who gets vaccinated against COVID. That is quite unfortunate, and it's something that we need to work much harder at fixing. Not all states report vaccinations with respect to race and ethnicity, and that is just flat out a problem. But for those that do, we see, just clear disparities where white individuals are vaccinated in some states at 4 times greater rates than people of color. Given the fact that people of color have disproportionately suffered the impacts of COVID-19, even from the moral standpoint of needing to vaccinate with equity, there's also the epidemiologic imperative to make sure that our highest risk populations have adequate coverage and access. So we absolutely need to work harder. And in my view, one of the ways that we need to address the vaccine equity problem is to expand access. In terms of other data, one of the challenges we've also seen is that we don't track testing with respect to race ethnicity. So if there are disparities in who gets COVID and who's hospitalized and who dies from COVID, it probably stands to reason that there's probably disparities in who is able to be diagnosed with COVID in the first place and who is able to access testing. We don't have those kind of data. Only a handful of states share data on testing with respect to race ethnicity. So that's one place where I would like to see additional breakdown of demographic data.
Thanks, Jennifer. We're coming up quickly on 12:30, so I'm going to wrap up. I'd like to thank Jennifer Nuzzo and Brian Garibaldi for joining me today, and give a big thank you to everyone who joined us, and especially to those who submitted questions for our experts to answer. This briefing will be archived and available on coronavirus.jhu.edu. And as a reminder, we'll be offering regular 30-minute briefings on Fridays at 12 p.m. In each briefing, we'll focus on what you need to know right now about the COVID-19 pandemic, and we'll have live Q&A with our experts. Another quick reminder that we recently launched our Coronavirus Resource Center newsletter called The Week in COVID-19, a wonderful way to receive the latest analysis from our experts on Mondays to your inbox, and you'll see the sign-up info is in the banner that's on your screen right now. I'll look forward to seeing you at our next 30-minute briefing, and until then, thanks and stay safe.